Well, welcome to our live panel discussion at The Spectator on the future of British healthcare. This pandemic has shown more clearly than ever before that our health is not just determined by our genes, but by where we live, how we live, our communities and opportunities. And those from poorer backgrounds or more densely packed neighbourhoods or less healthy diets have suffered disproportionately from the last 2 years. Now, in the future, British healthcare must take more and more of these indirect factors into account. And in clinical research too, that stage where the life sciences industry works with the NHS to develop new medicines and treatments. Too often, clinical trials aren't representative. Only 6% of those in COVID-19 vaccine trials were from ethnic minorities, for example, when 14% of the UK population as a whole are from Black and minority ethnic groups. There's also an issue of early diagnosis, where conditions like cancer tend to be found later in the most marginalised groups of society. All of this has a political salience too, of course, as this Conservative government's success or claim to success is built on the often deprived areas in the so-called red wall seats. So how can this situation be remedied to create an NHS that's fit for the future? That's the topic of our discussion today, held in association with and funded by the pharmaceutical company MSD. I'm Isabel Hardman, I'm the assistant editor at The Spectator, and I'll be chairing this discussion. I'm joined by Dr. Louise Kenny, who is the Executive Pro-Vice Chancellor of the Faculty of Health and Life Sciences at the University of Liverpool. Chris Green is the Conservative MP for Bolton West and the Vice Chair of the All-Party Parliamentary Group for Life Sciences. And Cham Herath is Executive Director of Medical Affairs at MSD. Welcome to you all. Thank you so much for joining us. Now, before we get started, if you're watching at home on Spectator TV, you can send in your questions in the Q&A tab just below the video feed, and I'll spend some time going through them later in the event. So on to the discussion. Let me start with you, Louise. I've got a couple of questions for you, but my first is really for those watching who might be a little unfamiliar with this, which is, what are the life sciences?
Thanks. Well, I guess the simplest way to define life sciences is that it's the study of all living organisms and the life processes associated with those organisms. And those organisms include plants, microbes, fungi, animals, and the very top or at one extreme and human beings. But in the real world, we also assume that life sciences includes the hard physical sciences that are applied to those organisms and processes. So by that, I mean the pharmaceutical industry, therapeutics and diagnostics, medical devices, and all products that are developed as a sort of side effect of the life sciences industry, which are used to treat or aid in the treatment of patients and animals and other living things.
Thank you. That's really, really helpful. I set out a few numbers in my introduction, but perhaps you could give us an overview of what health inequality is like in the UK and whether it's been getting worse in recent years.
Well, I mean, as you said, I'm the Executive Pro-Vice Chancellor of the University of Liverpool, the Faculty of Health in the University of Liverpool. And I was actually born and raised in Liverpool and studied medicine in Liverpool. And I studied medicine and worked as a junior doctor through the late 80s and early 90s. And even though I grew up in the city, I was on a daily basis confronted and shocked by overwhelmingly bad medical outcomes, clinical outcomes that were disproportionately shared across the city. You know, there's a huge, we talk about the north-south divide nationally, but there is a north-south divide across our city. And back in the 90s, there was a differential in terms of overall life course survival, a sort of difference of 12 years between women who were born in the south of the city and those that were born in the north of the city. I left Liverpool in 1997 and came back 4 years ago to a leadership role, and I was dismayed to find that those indices haven't really budged at all, despite the fact that Liverpool is now prospering in a way that it hasn't done for more than a century. The health inequalities have remained firmly and very unfortunately baked into our city. And I think our city is just a representative, a small representative of what's happening across the North nationally. We have huge inequalities between the North and South of our country, and also between urban and rural areas, and particularly bad outcomes in some of the northern coastal areas. And that's we're a small country, and I find that inequality quite perplexing. It seems to be largely driven by a mixture of drivers, but I think it all does come down to poverty in its widest sense, and in the 21st century, I think that's quite unfortunate.
Chris Green, just tell us a little bit about your experience as an MP. Does that chime with what we've just heard from Louise?
I think so. It's I think as society has become more mobile, people will move for work, and people will, like birds of a feather, collect together. So if people are highly qualified, highly skilled, very well paid, then they'll move to similar areas. And actually, because that's happened over many decades, you get these concentrations, increasing concentrations of wealthy people in one area, poorer people in another area. And it's all the other things that go with it as well. So I think that's one of the key aspects why it's so difficult to bridge this divide. And obviously, national government is incredibly important on this, but also local government as well. And it's very difficult for national government to drive this, because fundamentally you can have a one-size-fits-all approach. And I do think, in terms of the health and care white paper, having the integrated care systems, that to some extent this is what the government wants to do, wants to resolve by having the actual leadership within the health and care system far closer to the people.
Okay, and Cham, I mentioned in my introduction some of the inequalities in clinical research. What's your experience of that, and what's your experience of that in the pandemic?
Firstly, thank you for allowing us to sponsor this, and it's great to be with such a informed, eminent sort of panel. I think Louise and Chris have already alluded to the divides, and especially I think what Chris said there is that we have cities across the UK now more which have that inequality. One side of the city has a social deprivation and poor health outcomes, and other parts are affluent and have better outcomes. And usually the hospital or the healthcare system treating both populations is the same. And therefore, the one size fits all that we've seen historically being applied as an efficient method of delivering innovation is probably not the right way to go. And we need a better, I suppose, thinking at a local level in how do you implement innovation and access. And let's not forget, we have, over the last 15 years, been a country that has adopted innovation, right? So we should be having better health outcomes. And we've always had a great sort of clinical and scientific sort of research community that is world leading in lots of different therapy areas. And hence the reason why companies like ours like to invest in the UK and work and collaborate with the UK. So what we've seen throughout is not only has COVID and the treatments for COVID highlighted these disparities in inequalities, but also for the disease areas that have had to almost take a back seat to allow patients with COVID to be treated, have also been expanded in their I suppose, inequalities. So cancer being one of the key ones that is easy to identify. I mean, we know from the headlines from last year and the year before about over 25,000 cases being missed. But also when you look at sort of the new additional cases that are being diagnosed, say lung cancer and esophageal cancer, 30% of those are being driven, 30,000 of those are being driven by the fact that they are based on social inequality factors that drive those incidences. So the separation is not just about access to healthcare, it is actually driving the incidence of poor health in individuals. So it's something that we need to address. And I think the COVID experience has given us some insights into how we may approach that. But at the same time, I think it has left us in a situation where there is a lot of catch up to be done to get back to where we were prior to the pandemic.
Thank you.
One of the areas I think that has been revealed by the pandemic, and you got the educational divide. One of the key aspects of that is children's access to devices, a good internet connection at home, and places where they can learn. So that's a challenging start for people's lives. And that's so important for what comes on down the line. But in terms of what we're looking at in terms of medical advances, there's a lot more in terms of what people can do themselves and managing their own health. And there's a big question over that. Who was most able to be able to manage their own health, to understand what they're doing, why they're doing it, and be able to access the understanding and the technology to be able to do that. And it goes into that whole narrative understanding about the digital divide in our society. So perhaps the people who are already advantaged will be able to take more advantage of the potential that comes down with these advances.
When you say people who are able to manage their own health, I think one of the reactions that people listening might have is, oh, does that mean people who the NHS doesn't need to bother with? Just explain a little bit more about what you mean there.
It's there is so much more that can and should be done. For example, just having the right technology. If you're wearing a piece of technology that monitors your heart rhythm and you go about your normal daily life, the fact that you can upload or have the system perhaps of technologies monitoring it, artificial intelligence, you can actually assess people's healthcare on a daily basis. That can then be transmitted back into the system, and therefore you've got a far better way of appreciating someone's health and when and where they have actual problems. Now, if someone can engage with and use that technology and have those conversations with the doctors and what they're doing, how they're going about their lives, that relationship actually enhances the ability for the medical profession to support them and their healthcare. When you get into more complicated areas as we come down the line, I think that challenge, if people aren't educated in the right way, are given the right support, their ability to actually have that ongoing relationship with the profession, as opposed to being told, take these pills, go home, I'll see you in a month's time.
Fantastic. Louise, how easy is it for the NHS to move to this kind of model? I mean, we do know that was it a tenth of all NHS trusts are still largely paper-based? So this sounds like quite a leap for quite a few of them.
It is, and it will be. But if there are any advantages, and I strongly believe there are no advantages to having a pandemic. But one of the things that's come out of the COVID-19 pandemic is that it has driven home that we are amidst a sort of data and technological revolution. But our ways of working perhaps haven't responded to it as agilely as perhaps they should. And digital exclusion, digital poverty, particularly in areas that are already etched out as having unequal, unmet health needs, is a key barrier. So I think there is both a challenge and an opportunity wrapped up in one there. How do we move? Everyone's heard the expression that data is the new oil, and personally, I think that's a really unfortunate analogy, because for a variety of reasons, I think data is far more enduring and far more valuable than oil, and also nowhere near as toxic. But as we move to really exploiting that, we've got an infrastructure that does not allow us to be as agile as we can. If you look at some of the Scandinavian countries, they are way ahead of us in terms of what they can do with their health data, because they have a collective approach. They've been they've future-proofed their healthcare systems. They've grown a culture of a community and acceptance that people expect that their health data will be used for the greater good of society. We haven't even really outlined those principles yet, and we certainly haven't adopted them as a country, and that's really holding us back. If you think about, just even the north of England, we have, if we network some of our key areas across the north, we'd have 16 million people. Now, that's a huge population that's literally on our doorstep. It is unfortunately a population with significant health needs, significant disease levels. What we could do with that data would surpass anything that's coming out of the much smaller Scandinavian countries, just in terms of statistical power. But we've been really slow to harness that potential. Fortunately, as I say, I think the COVID-19 pandemic has actually illustrated what we can do when we think creatively and we are agile. And there are now several really exciting initiatives that are in play that I think will accelerate our journey towards that ambition, including the onset of CIFA, the integrated healthcare system for population health in the north, which I think will be a huge engine for innovation and will provide key answers. But on the ground, we've still got a long way to go.
I bet you have a perspective on how good the NHS is at innovation and technology.
Yeah, no, I mean, I totally agree with Louise. I mean, I think when I started out in this industry about 18 years ago, when we were approaching maybe introducing a new medicine to treat a particular disease, a lot the initial stuff was just trying to understand what is the extent of that disease in the UK. And it was very difficult back then. You'd have to go to different groups and collaborate and try to, cobble the data together, right? What has changed over the last 18 years is that there are better systems in place in the NHS. But as Louise pointed out, we still haven't addressed the principles of how do we access that data, how do we analyze that data, and then utilize it to inform healthcare provision. And we're still struggling in the pharmaceutical industry with the same problems of looking for collaborators and partners to say, look, we need to better understand the demographics of lung cancer in Manchester or so forth, and how do we do that? But there have been great examples of digitization and trying to think out of the box, so to speak. So, for example, Salford, along with one of our competitor companies, GSK, put together the Salford Lung Study some years ago, which digitized the records, both primary care and in a hospital setting, of all the patients in that region. So it allowed to be able to follow that individuals from the primary care GP setting into their hospitals and get a better understanding of the challenges of a given disease, and especially in this case, it was lung disease and issues there. And then we've also got something called the Crpd Database, which has been going for some years now, which has over 30 million records of individuals anonymized that can be utilized for research, and they're now joined up with hospital there. So we have got it. And I do always get annoyed when Sweden examples brought up, right? Because actually Sweden hasn't done anything more different, and we have the same infrastructure in place to be able to do exactly what Sweden and some of the other Scandinavian countries do. And all we just need is just a centralized, cohesive approach and some principles to put in place, And I think to safeguard, the control of that data should remain within the NHS and within academia. And then I think we have a system in place currently where you can, apply to do research with that data in an anonymized fashion, which protects the individual, but also still maintains control of where that data goes to and how that data is utilized. So yeah, it'd be good to see that. And as Louise said, I think the pandemic has moved us along a bit, but it remains to be seen whether that lasts into the endemic phase.
Well, I think it's house style at the Spectator to mention Sweden as often as possible, but thank you for that. Chris, one of the questions I have is, we talked about the pandemic in some senses, speeding things up, giving us a greater awareness of changes that the NHS needs to make. But your party is reorganising the NHS again, having done it 10 years ago. Does this not slow things down, or is the new health and care bill actually going to be the great technological and innovative panacea that the health service has been waiting for 75 years?
Well, it has potential to do that. Whether we realise that potential is a very different matter. I think there's a broad consensus that the Lansley reforms didn't quite deliver what they were supposed to, and that there does need to be some reversing of aspects of that. One of the problems is, as a broad problem with government, is so much of the power is put at arm's length organisations. And when something happens, ministers have to make decisions, and they can't. They're held to account for what is going on, but they don't have the authority or the ability to demand that things are done. They have to work in a very slow way through the system, and perhaps...
Do you mean that with respect to NHS England as a whole as well? Because the bill does give the Secretary of State a great deal more power, doesn't it?
Yes, so that is part of it, drawing power back to the Secretary of State to have more of a decisive decision-making process. But I think for people outside the NHS or outside of the life science sector, people would look at the NHS and think, this is our national health system. It must be integrated. It must work together, whether it's the GP working with the hospital trust. It all must function as an entity and be coherent. It isn't. It's a very long way from it. And it is quite interesting, as was mentioned about Salford. In the conversations I have with different groups, the number of times that, as a local MP in Bolton, it's just down the road, the number of times I hear Salford brought up, because fundamentally, I think that's about that leadership in Salford. It's about how they lead, how they work with other organisations, institutes from around the country. Also, I think that relationship with the private sector ought to be more fundamental, more engaged. And the NHS data is a huge resource, very sensitive politically and very sensitive about how an individual's data is used. So the point about having anonymised data is immensely important. But that resource, that I think many people will be happy for the NHS, happy for universities, other organisations to use in a very controlled way, but that should be used and made available for more and better research to really take on the challenges, because people are demanding more and more better healthcare. And one of the aspects of that is the easy or the big diseases or the big conditions have by and large got pretty good treatments, and you're increasingly going to the territory of rare diseases or more difficult diseases. You therefore need larger bodies of people for your studies. So this is on a UK-wide, and this is internationally as well. So these relationships, these collaborations are key. And actually, the National Health Service doesn't meet the expectations that people would reasonably have.
Louise, you were nodding away in that. We've had Sweden, we've had Salford. Have you got another location, preferably beginning with an S, that you want to
sadly, no, but there's 2 points I do want to just pick up on, because I think they're worth just sort of hammering home. So I think the current round of NHS reforms present an unprecedented sort of once in a generation opportunity, really, that at the moment I'm concerned we're not going to exploit. And that's really to embed R&D at the heart of the NHS. I've sort of combed the bill from start to finish, and I've looked at the MOUs that underpin the 30-odd ICSs from Cumbria down to the Scilly Isles, and
that's memorandums of understanding.
Memorandums of understanding, yeah.
Integrated care systems. There.
And yeah, so I'm an NHS person, so we're very good at speaking in acronyms
and jargon.
But I was quite disappointed, as were many of my colleagues in the sector, really, to see that research was really not embedded in the bill, and nor was it really reflected in the memorandums of understanding. And I'm part of a group of colleagues and entities across the sector now that it includes the Medical Schools Council, the Association of Medical Charities, a variety of people, and funders, who are really asking to just pause and see if we can actually embed or encourage in some way, mandate for research to be core business for the NHS. And the reason for that is very simple. When we talk about health inequality and adverse health outcomes across the UK and why they vary so much, one of the it's very simplistic, and in fact I think it's overly simplistic to say it's social exclusion or poverty. One of the reasons why outcomes are not as good as they could be is that research is often not actually performed where patients are sick. So if you look at Oxford and Cambridge, that absolutely, don't get me wrong, the research coming out of those organisations are amazing. It's amazing. But actually, most of the sick people are in Blackpool, they're in Liverpool, they're in Newcastle. And R&D spend is really disproportionate across the country. There's an inverse proportion, there's an inverse relationship there. And so I think we've got an opportunity to embed or mandate or encourage RDI activity within the new NHS post reforms by making it someone's responsibility. That, you know, it's not just nice to have, it's not just something we do in the margins of our day jobs or when we've got time, because quite frankly, you know, in the NHS there's never time and there are no margins, but we make it core activity. And apart from the fact that would be an enormous contribution to levelling up. I mean, it would level up in a huge way. It will also have a really profound effect on patient outcomes. We know from work done in a variety of different healthcare systems all over the world that the single most independent thing you can do to improve health outcomes is to offer the opportunity to take part in research. Because if you're taking part in research, you're either going to get the standard of care or possibly the next best thing. And we know time after time in a variety of healthcare settings in a variety of countries that if you are being cared for in a research rich environment, then your outcomes are on average 30% better. 30%, I mean, that's massive. And so I think we do have this huge opportunity, and frustratingly, it's not about funding, although, you know, as an academic, I'd always welcome more funding. It's mainly about making research, you know, core business and not nice to have. And I think, you know, we do have this unique opportunity, partly because the Act is in play at the moment, and also because, you know, if not now, in the post-pandemic recovery era, when we've never been more attuned to the impact that research can have on health outcomes than when, you know, I absolutely have always believed that life sciences can be a central plank of the levelling up agenda, but it's also going to be an absolute central plank of our inclusive recovery from COVID. And I think the key word there is inclusive.
Cham.
I mean, I wholeheartedly agree, and I think from our pharmaceutical perspective, it's exactly that levelling up that would achieve that is really important to us, because it would allow us to provide access through the clinical study framework for the most that need across the UK for new things. And as Louise said, you know, these studies are done as standard of care versus the next best thing, right? So obviously it isn't still without risk, but at least the individuals in all those localities will have the opportunity to make an informed choice of, do I go into that study and try it out. So that's what's missing today. And I think Louise touched upon it there, is what we have is academic research is polarized from clinical delivery. And I think, you know, what we do have this opportunity to marry those together across the UK currently, and therefore we won't be in this artificial thing of which we currently have, which we generate the data of clinical efficacy and safety of a given drug. It's assessed by bodies like NICE and so forth. Then the NHS has to work out how is that it deployed, right? So if you're doing studies in across the board, in especially in those areas most at need, you will have the variety and diversity of population of people coming into those studies. But moreover, as you're doing the studies, you can work out what the clinical delivery of that particular therapeutic intervention should be like going forward. And we've seen some of those examples in the pandemic, you know, with studies that have been created. But it is an opportunity, and I do worry, like Louise, that we may lose that opportunity, you know, because we've been here before historically, but not to this extent, you know, where I think all parties are aligned on what we need to achieve.
Chris, just to come back to you on some of the points that have been made about the legislation, I wonder whether you agree with what Louise and Cham have said, but also whether practically what could change. I mean, there's been a lot of debate around the bill, as you'd expect with anything to do with the NHS, around the role of private companies and, you know, whether they should be allowed to sit on integrated care boards, for instance. Do you think that there should be a greater representation for R&D on those boards? How could the leadership of integrated care systems ensure that R&D is part of the sort of ethos of that area? I wonder what your thoughts are on that.
In the bill itself, the language is so vague. Any integrated care system can have as much or pretty much as little relationship with R&D or innovation as it likes. So the requirement's almost not there. So that does come down to leadership of the 40 or so, the 40 plus integrated care systems around the country, who sits on those boards. what makeup you have in terms of officials from the NHS or the wider health system, business, industry, universities, those who are more focused on the R&D side of things, and to get that culture shift. Now, my expectation wouldn't be that every single integrated care system is going to be a leading innovator or will have those amazing relationships with the sector, but I would hope and I would expect that sufficient of them, perhaps maybe a relatively small number, but sufficient of them do, and they become the leaders, and they become those role model organizations that others can and will and have that pressure, that demand, perhaps from the Secretary of State, but also I think from the bottom up. If we can have more clarity over health outcomes in a particular area and more ability to demand from those leaders who sit on the board, what are you doing? What are you achieving? How are you engaging to deliver these better services? Why is the neighbouring system so far ahead in one particular area? Perhaps we're ahead in one, we're behind in others. How can we make sure we level up in all sectors? And I think there will be individual areas that will take the lead. And it, to some extent, it goes back to that point about Salford. Why is it, how is it that a particular hospital trust gathers and creates that culture that perhaps then draws more people in who think, I could work in a number of different places. Now, why do I want to work here or here? Well, I know if I am interested, I've done my medical degree, or I've done my PhD, whatever it might be. If I want to take it up to the next level, if I want the huge opportunities, this is the trust or this is the integrated care system I want to work at.
I think right in that we can't expect all of the integrated care systems or partnerships to be, you know, at the forefront of our RDI. Much as that would be wonderful, I think it's a completely unrealistic expectation. My worry is that those that are currently succeeding, which are largely clustered in the Golden Triangle, will continue to flourish and succeed. And yet the majority of patients that we're talking about who are currently excluded from research because it's not happening on their doorstep in the localities where they live and unfortunately die prematurely, that won't change. And yet we do have universities across the north of England who are, you know, willing and ready and able to take part, but there's no incentive, there's no encouragement. You know, we're locked out of that process. You know, I think the language is vague, but a small tweak to the language to sort of encourage that in areas where there is, for example, a Russell Group university and a medical school, they should be part of the integrated care system. They should be part of the culture that says, you know, we're here and we have a lot to offer in terms of our life sciences RDI and the communities that we seek to serve. You know, across the north, we have great red brick civic universities, and the emphasis there is on civic. We seek to serve the population that we are embedded in. Yeah. But at the moment, we're, you know, in some ways, we're effectively at best not incentivized to do that, and at worst we're actually sort of blocked out of it. So I think it would be great if there could be some sort of central incentivization or guidance, because I'm really concerned that without that we'll migrate into the after the act into a new normal, and that will look very much like the old normal, where there is a large cluster of activity and funding in areas that do research excellence but are absolutely remote from the majority of people who are sick and need access to research.
Well, there's a...
Sorry, Chris,
sorry.
go ahead. No, go ahead. I'll jump in. No, okay. What was I going to say? Sorry, is I totally agree with what you said and Louise said, but I also think that going back to your comment about Lansley, I think there was one thing in the Lansley vision for the NHS which was more to empower the patient and hear the patient voice. I don't think that's really occurred, and I think as these ICSs are created, as well as being inclusive at the board level of research and everything else, they must prioritise hearing from those communities. And Louise, I totally agree with you. I mean, you know, some populations it's really difficult to access, but they should be incentivised to hear from them and get that. I mean, we at MSD, I mean, to solve one of the diversity inclusion problems with clinical studies, actually went into students from diverse communities and said, here's our problem. So they're not subject matter experts about running clinical studies, but we said, our problem is we're not attracting people in. So what do you think? And the wealth of recommendations and ideas was bowled me over. And moreover, we're implementing those this year. So I think definitely getting that patient voice and the population voice rather in the area is really critical for the success of ICSs, and also understanding how to implement a given pathway.
Chris.
I think the Northern Health Science Alliance, they've highlighted or report a Northern Life Sciences supercluster. So I think there is some work, there is some focus on this. And I, as a conservative, I instinctively like market forces, but also the levelling up agenda led by Michael Gove. I don't know what's going to be in the report, the white paper that's coming out in a couple of weeks or so in terms of levelling up, but I'd expect life sciences to be part of that, especially as the government's got that ambition to increase percentage of GDP spend on R&D to take it up to 2.4% by 2027. A significant part of that has to be in this area. And to have the UK focus just in the Golden Triangle, I think, is a problem. Now, we need to be competitive to make sure that industry and collaboration works in the UK. We need to be globally competitive. And so we ought not to be undermining them, but to have so much concentrated in one section of the country. I think whether it's the clinical trials, those relationships that researchers can have with whether it's universities or whether it's the GPs or local hospitals, you've got to have that. And therefore having a second hub in the north of England, ideally, and I'll be thinking Liverpool, Manchester, sort of South Lancashire, North Cheshire would be, I've got a slight bias from Liverpool, worked in Manchester for a long time. But having that second concentration, and this is where levelling up fundamentally has to be an intervention, recognising that market forces haven't delivered, and we in the UK are actually underplaying our strengths. And by having that second hub, actually, I think it'll be mutually beneficial to both.
Fantastic. Well, we have got loads of questions from the audience. Thank you to everyone who's been sending them through. So we're gonna move to a discussion of those questions, and I think a really good one to start on comes from Tim, who asks, what is a life sciences superpower? What measures or metrics does the government need to set and achieve to meet this aim? Louise, let's start with you on that question.
Yeah, so our life sciences superpower, well, I mean, we are fortunate in England in that we have some of the most prolific, world-leading life sciences superpowers and clusters. You know, and for all my talk as a northern girl about the Golden Triangle, I am super proud of what's come out of both the Cambridge Science Park and the Oxford cluster, particularly during the pandemic. You know, we've had a huge global impact in terms of our diagnostics and our vaccine work. And you know, we just mentioned the Northern Health Science Alliance. I'm on the board of the Northern Health Science Alliance, and I think, you know, across the north we're now working collaboratively to pool our resources, which are complementary and yet very different as you look from the west to the east coast, to come together as one, showcasing to the world, to the country and the world actually, that we have a diverse and yet collectively, you know, world-class life sciences capability. It's spread across a wide geography, but actually when you cluster it together, we are punching way above our weight. In terms of how we, you know, what sort of metrics you apply, I mean, as a clinician, I'm always going to come back to things that make a hard difference to health outcomes. But they're not just the traditional health outcomes that we think of, you know, in terms of, you know, crude indices of mortality and morbidity. I think, you know, as we move into this century, further into this century, and we look at some of the other challenges, we can now look at how, you know, the interaction between things like how we are mitigating the inevitable impact of climate change on health, how we are perhaps how life sciences clusters, super clusters actually level up. You know, it's no good exceeding in terms of winning health outcomes in one area if you don't share the joy. And you know, as a woman, I'm also particularly concerned about how women as a whole have been left behind in this endeavour. And you know, I'm delighted to see the women's health strategy coming to the fore this year, because I think that's a huge step forward from this government in terms of how we can address that. And then there's also, you know, and this will be central to our post-COVID economic recovery plan, hard metrics like RDI activity, investment inward investment into the country, and how we are also generating high value jobs, and generating not just the high value jobs but also educating people with the right skills across the country to fill those high value jobs. So that there's a catalogue of metrics you could apply, but I think we need to think a little bit more, in a looser sense about what good looks like and how we measure it.
Fantastic, thank you. Chris, what are your aspirations for a life sciences superpower? I wonder whether, the description that Louise has just given us makes me feel like we already are as a country, and yet it doesn't seem to be part of our identity in the way that the NHS is.
Well, I think, listening to colleagues in Parliament, those who are based in Cambridgeshire, Oxfordshire, towards London, they are far more likely to talk about the R&D side of things, the life sciences sector, to a certain extent because there's such dominant industries in that part of the United Kingdom, and therefore, by being so concentrated in those areas, and MPs are very responsive to concerns and interests in their constituency, by it being in one corner of the United Kingdom, I don't think it's discussed and raised as much in Parliament and more widely. Therefore, having a better geographic spread, I think, will give that awareness and that interest to some extent in people growing up, going through school, getting their education, going through training, and actually to see the opportunities, to see, actually, if I focus my education in the sector, because I've got opportunities close by, rather than having to go travel 200-300 miles to get that good job. But it's not just those top level academics, it's also technicians and other people who perhaps wouldn't travel quite so far for those opportunities. I think it's that educational side, that understanding side is immensely important. But an aspect I'd like to see, two aspects I'd like to see far more of, is the National Health Service can be pretty slow sometimes at adopting new technologies, whether it's from the pharmaceutical sector, whether it's medical devices. We can be pretty slow in comparison to Germany and France at adopting these new technologies. So I'd like to see that advance. But also, I often, occasionally reflect on the other end of the R&D process, the actual manufacturing side. I think the AstraZeneca factory in Macclesfield is its production is worth about 1% of the UK's export value. So if we can have more factories, as well as the R&D at the beginning, the collaborations in the NHS, but also the manufacturing side as well, I think people would see increasingly that the life science sector is where you can get a good job, a well-paid, a highly skilled job, and actually it'll be a huge benefit to the country. And that's, so I don't know about a definition of a superpower, but I'd like to see that beginning, middle, and end in the UK.
Yeah. Dan.
All I've got to add to that, I think, and Louise and Chris have sort of alluded to this, is I think any metrics we apply have to apply to the whole pathway, right? So it's from metrics about how good are we at the research, how good we are at the manufacturing, and then the health outcomes, and then also the implementation. So it's no good just to look at the health outcomes and say, well, we've improved those, because actually that doesn't allude to it. And whilst we have got great examples, and I used to be medical director at AZ, Chris, so you're right, it's 1% of GDP, but actually when you look at the manufacturers and the vaccines, a large portion happens outside of the UK, the pandemic. So we should be looking at how do we reverse that in terms of being able to have those capabilities. And I think Chris sort of mentioned it, it's part of that is awareness, and you asked the question right at the top, Isabel, about what is life sciences, right? So we need to foster that education as well about different areas, and for example, ICS boards, understanding what it's about and the opportunities it can bring from our perspective. So we are investing. Companies like ourselves are investing. We're building a new life sciences discovery centre. But what we find is actually to spread across the UK is very difficult, because in certain areas the infrastructure doesn't exist. And I think, for me, I think it's having a consistent and infrastructure available in these different hubs to be able to do it.
Thank you very much. Let's go to a question from AJ, which is, which hospitals best blend research and medical treatment, and what can be learnt from them? Cham, let's stick with you.
So what I can say is, from our perspective, and I trained at St Mary's, which is Imperial now. So those ones and teaching hospitals as general tend to be the better ones at integrating both, simply because I think the academic and the research part is better integrated into the clinical part. So you have departments that deliver clinical healthcare that isn't devoid of academic individuals that also sit in that department. So and therefore things like outpatient clinics and so forth are run with one eye of those people in the outpatients, understanding which clinical studies are running that are relevant to that patient population being seen in that clinic. So for me, I think it is probably teaching hospitals. I wouldn't, go further than trying to pick out individual hospitals or so forth. But I think, where you see the success is where there is that cohesion, where all staff members understand what the clinical research priorities are for that hospital and what they're involved in from that perspective. And I think that's where then in each consultation, you have that discussion with a patient, say, look, I can treat you like this because this is a nice approved treatment. However, we do have a study that is doing this. And I think, that's what we see. Liverpool, Manchester, are great examples as well, being, great seats of teaching hospitals and academia.
Chris, you mentioned Salford earlier.
Yes, so I'd normally highlight Salford because so many people do raise it, but it's not necessarily about every hospital or every trust being Salford around the country. It's also about the participation. So you might have the very academic elements concentrated perhaps in certain trusts, but how do other hospitals, how do GPs relate to that? How do they connect? Because a great deal of it is about awareness and having these conversations and saying, you come to our GP surgery, or you'll come to our hospital, but we're aware of this collaboration, we're aware of this treatment, we're aware of this alternative, we're aware perhaps of, rather than you coming in all the time, what about this technology you can take home? All of these things, I think, by having that complementary approach, people can access it more because the system is more engaged. Now, how do you get a hospital or a GP who will already say they're overworked, they can barely cope with what they have to do at the moment? How do you get them to participate in that way? And I think that's a huge challenge. And I don't think I can answer it at the moment, but that's one of the big challenges in terms of this participation. But we have to break this kind of just about coping mentality. We have to break into that to make sure you can create a more virtuous circle where you have better technology, better treatment. That frees up money, that frees up time to enable some of that time then to be spent on these more R&D-led or innovative-led processes.
Louise, what do you make both of that question and of Chris's point there about ensuring that there's actually capacity to do this work?
Yeah, no, I fundamentally agree that capacity is a huge thing. And I also agree with Chris in that, in a truly integrated system, there will be those that do and generate and those that just offer the participation, because we know we can't all be world-class at experimental medicine, but I fundamentally believe that the trials that result from that experimental medicine should be offered, nationally to everyone. No one should be excluded, and that it means that being inclusive doesn't necessarily mean that everyone does the same thing. But I also agree with Cham that in general, the hospitals or the institutes in which RDI is delivered at its best in the UK are in those university hospitals that are affiliated to the medical schools traditionally. And in the latest or most recent iteration, that's kind of been recognised. The most high performing of those organisations have been recognised with academic health science centre designation, and that in turn, the concept of an academic health science centre really sort of sprung out of, amongst other places, the Karolinska Institute, where the Karolinska is hand in glove, a university in a hospital, but the two are seamless. You're in the university, but you're in the hospital, and it doesn't make a difference between the two because they are one entity. And the minute you walk through the door of the Karolinska, it's not just, research is just not expected. It's going to happen because you're in a completely research saturated environment. And I think, that's what we aspire to. And we're a long way on that journey now, mainly thanks to the foresight of Sally Davis and the inception of NIHR and the massive difference that NIHR as an entity, and NIHR in terms of its funding capacity has made to medical sciences, life sciences and medical sciences research in our country. I'm going to say this, I would say this, there's lots done more to do. But when I think about what the life sciences RDI funding landscape was like when I left the UK in 2006, and then I compare it to what it was like when I came back in 2017, it has been transformed by NIHR. Now we've taken a challenge recently with COVID, and I think, NIHR in the wash-up will have been shown to be one of the key differentials in terms of what we did good in the pandemic. And I'm really excited for what comes next, and if we can increase that, the RDI spend, in terms of GDP to those ambitious levels, I think the future looks really bright. So, I think, academic health science centres, and we could do with a few more of them. We'd certainly love one in Liverpool.
It's really nice to hear somebody saying they're excited about the future after this pandemic, and actually about the way that this pandemic can affect life sciences and research in a positive way. But I guess one of my questions off the back of what we've just said, and we've talked about capacity, we've talked about changing the way that hospitals operate, is the NHS has a huge backlog, record backlog to deal with. Its staff are exhausted. It's not just a case of vacancies and enough people to carry out the work. The people who are there are also really struggling. So it is now really the time when change is going to happen, Louise.
Yeah, I mean, I think it's a really good question. But I think, if the change reduces, increases efficiency, reduces a little bit of redundancy, and increases the way that we can perform in an agile setting, then now is a perfect time to do it because of those capacity issues. So I think it's not without risk. And I won't rehearse the concerns I've got again about the missed opportunity that the bill represents in terms of taking some of the learnings from the pandemic and embedding RDI activity. But I think if we can increase efficiency, reduce a little bit of redundancy, and actually adopt agility nationwide, then I think it will be surely only good can come from it. But it's not without risk.
Okay. Let's move on to another question from, actually, I don't know who this is from, so thank you, whoever it was from, because it's a very good question. Why does health only involve healing and not enough emphasis on prevention? We'll go to you first, Chris.
Well, I think there's increasingly a focus on this aspect of maintaining people's health rather than sort of repairing people afterwards. And so no doubt there's historic reasons for it. And this ought to be a requirement, and that every structure in the National Health Service ought to have more emphasis on. But I suspect one of the reasons why it's quite challenging is the funding model that's used at the moment. If a particular department spends its resources in one area, creates savings, it doesn't actually necessarily create the savings for itself, and therefore it isn't motivated perhaps to have probably the best intervention. So having a smarter funding system where if you perhaps put some more money in, you innovate, you try to protect people's health rather than let them become ill and then treat them afterwards. But actually your funding is protected, or your mechanism, your ability to do that is protected. So I think that's one of the aspects, is the NHS hasn't in that sense evolved its model or evolved its approach to treating people. And this might be one of those areas where the integrated health systems can be far more flexible, and within that system, within that framework, can more manage those fundings. But I fundamentally think an aspect of it, there's cultural shifts. but unless the funding model is right, it's going to be very difficult to do that.
Isabel, can I come in there? Yeah, so
yeah,
I do agree with Chris that, you know, it's there are multiple aspects to it, and it's not easy. But I think just taking a helicopter view, prevention is really hard. You know, so if we just take, and I come to this with a huge amount of bias because I'm a women's health researcher. You know, my day job is an obstetrician, and my research is in women's health outcomes. But if we just take the standard NHS cardiology clinic that will see, you know, in the course of an afternoon, maybe 60 patients with cardiac disease, much of which might be atherosclerotic, you know, coronary artery disease. We know that about 50% of that disease burden actually originates in the first 1,000 days of life, and yet it doesn't manifest until 5 decades later. And so that makes prevention really, really hard, because for every pound you spend now, you're not actually going to see the benefits, possibly for 3, 4, 5 decades. And in a pressured funding environment, there are short-term, you know, much more, burning platforms that need to be attended to. And I also think that what feeds this is because, you know, everyone is the result of a pregnancy, and how that pregnancy and that, you know, as I say, those first 1,000 days go actually will determine your life course in a really profound way. You know, probably 50% of disease burden, if not more, and certainly in some disease areas, that the nurture bit, the first 1,000 days is far more influential. And yet we do have this disparity in terms of funding. And also RDI in women. You know, you will have seen that we've all seen a lot of coverage recently about the fact that women are often excluded from clinical trials. Pregnant women are excluded from almost all research. And we've come a long way in the last few decades from recognizing that actually we're not protecting women by doing that. We're actually creating huge health inequalities by excluding women from research. And we've even seen that with the vaccine research recently. So, you know, prevention is hard, it takes time, and the outcomes are a slow burn. And I think what feeds into a lot of health inequalities that have their roots, you know, could be potentially prevented, is the fact that the time to prevent them is in pregnancy and early infancy. And research and funding has just been absent from that area for the best part of the last century. And that's why, you know, I mentioned it earlier, I was so delighted to see the Women's Health Strategy. Because although that's about women's health outcomes in the rounds, you know, at the core of that is about RDI as well. So that's another aspect to it.
And just to
really
add to that,
interesting
sorry,
to chip in with, just let you add in, but I just want to add my own question as well, which is that the point that Louise is making is quite a challenging one for pharmaceutical companies, because the reason that pregnant women aren't included in trials is for ethical reasons. And I can imagine that a lot of companies would be thinking, yeah, someone else could include the pregnant women in their trial because we don't want to have the trial that messes up.
Yeah, so I mean, I think this goes back to some of the areas where we need better collaboration between the industry, between researchers and clinical, providers, and then also the regulatory authorities, because there is an approach you can take which safeguards the mother and the unborn child in doing research, but the onus can't be just on the pharmaceutical company to deliver that. It has to be an agreed approach on how best to do this, and also, I suppose, with the risks involved, where we need to do it, from that perspective. But as Louise said, I think it all first starts also with grassroots research being put into it from that perspective. And what I also wanted to add is also, when we talk about prevention, what we also need to talk about is there is obviously a therapy area related prevention, but then also we rely on primary care to sort of soak up the rest of general public health prevention, right? And the way that our commissioning system works currently today is that if you're, say, a HIV physician who wants to give a vaccine to your HIV patient, you'll have to refer them back to primary care to have that vaccine. Whereas, it's easier in the old system where me being a HIV physician, where I could be able to give that vaccine there and then, because I felt my patient was under risk. So I think we need to look at how flexible, and Louise sort of mentioned the word agile, we are in funding streams to allow different professions and different specialities to take a broader perspective on prevention from that perspective. And I think finally that it is doable. That if you look at things like HPV vaccination scheme, that is over time now delivering reduced amounts of cervical cancer, right? So, and Louise's point of in-year sort of fund savings versus savings in healthy outcomes over years is really important. It's something we need to adopt more and more of, you know.
It's it becomes there's a huge political challenge, I think, in this, assuming limited resources, or it's how you deploy those resources. And fundamentally, if you have limited resources, how can, whether it's at the national level or more local level, if you're redirecting resources, where the vast majority at the moment is kind of end of life, towards the end of life, if you're taking a proportion of those resources away and directing it at young families or pregnant women, that's a big decision to make when people are going to be reacting to the healthcare that they're offered at the moment. So I think it's broadly the right way to go, those early interventions, but it's a very challenging decision to actually make.
Well, I'm afraid that we have run out of time. I know that all four of us could have gone on for several more hours, and thank you so much to all three of you, to Louise, Cham and Chris, for joining me on this panel about the future of British healthcare and how we can become a life science superpower. We've had so much food for thought. Thank you so much to MSD for sponsoring this really important discussion. And to all of you at home, thank you so much for watching and for your really interesting questions. I'm sorry we weren't able to get through all of them, but I think we had a really meaty discussion. So thank you for your contributions to that. Now, you can rewatch any part of this discussion on Spectator TV shortly after the live stream ends, and we hope to see you on another Spectator event in the near future. Thank you everyone for taking part.